Hello everyone. My name is Stephen Connor. I'm the Executive Director of the Worldwide Hospice Palliative Care Alliance. The Alliance is an alliance of all of the regional and national hospice and palliative care associations worldwide. And our primary purpose is to advocate at the global level for palliative care and hospice care, but also to help in developing palliative care globally, particularly in low and middle income countries. And we work with our members. We have members in 86 countries, 285 at the moment members. That includes associations, but also academic institutions and other groups in countries where palliative care is part of their mission or their whole mission. I've been working myself in palliative care for 40 years in a variety of capacities. I'm licensed as a clinical psychologist and work just in hospice care all these years, running programs, doing clinical work, teaching, writing. I have written several books on hospice and palliative care and have published a lot of articles, do a lot of research, and try to help us, with the evidence base for palliative care. So what we're currently, we're in official relations with the World Health Organization as an NGO, and in the first 3-year period that we were in official relations, our primary project was the development and publication of a book called the Global Atlas of Palliative Care at the End of Life, which is an advocacy tool, but the atlas essentially paints a picture of palliative care globally. It answers questions like how many people need palliative care, what are the barriers to palliative care development, what are some of the resources that we have at our disposal, what are some examples of good practice throughout the world, and what some of the policy recommendations on what the way forward is for developing and overcoming the challenges that palliative care faces. We used an approach to mapping levels of palliative care development, which is structured at 6 levels. From no one's doing palliative care in a given country, and we can't even find people who are interested in developing palliative care. That's the first level. The second level is that there are people who want to develop palliative care, but there is no service delivery. The third level is in 2 parts. Beginning of provision of services, so there's at least somebody providing palliative care, and then more where there's a body of providers in the country that's not yet integrated into the healthcare system, but that exists and cares for patients. The fourth level is integration, and that's also in 2 levels: beginning integration and advanced integration. At present, only 20 countries in the world, at the time we did our last measurement, had reached the level of advanced integration. And as you might imagine, those are countries in North America, Western Europe, and Australia and New Zealand principally. One of the things we did was look at where the need was for palliative care, and a minimum of 20 million people annually at the end of life need palliative care, and we think that's probably an underestimate. We actually double that to account for people who need palliative care before the last year of life, so that's 40 million people, which may be a bit closer to where we think things are. And 80% of those people, just about 80%, live in low and middle income countries. So we're not so concerned about helping develop palliative care in high income countries because they've already got it and are doing reasonably well. Our mission and our focus is to help develop palliative care in low and middle income countries. And we have begun by selecting 6 countries that we, one in each WHO region that we're focusing on at present. We currently have projects running in Bangladesh and are beginning one in Ethiopia on palliative care at the community level. A lot of this is focused on how do we build palliative care into the existing healthcare system. It's not to create standalone palliative care providers, as is the case in many countries, but to work with governments and with medical schools and nursing schools and other key stakeholders, including the leaders of palliative care in a country, to help build them up, to help them take palliative care forward, but to give them the resources that they need to begin to do that, and be available to them as they struggle and try to develop palliative care. The other countries we're focused on at the present are Ukraine, Jordan, Philippines, and Panama. So those are the 6 countries. There are an additional 6 countries that WHO has chosen to do demonstration projects in, and we've also committed to helping WHO with development of palliative care in those countries. I think since the passage of the resolution on palliative care at the World Health Assembly in 2014, this has been our moment of opportunity to develop palliative care globally, and so we really are putting all our efforts into doing so that the resolution isn't just words, but actually it affects the lives of people. And we used basically the public health model that WHO developed a long time ago in palliative care development, which is really the triangle based on policy, education, medicine availability, and then the implementation of services. And within each of those 4 areas, there are major milestones and outcomes and things that need to be accomplished for palliative care to survive and thrive in healthcare systems these days. So that's a brief snapshot of what we're up to. We run a service called Hospice International, which is a communications tool for people to share best practices and big policy things that happen globally in palliative care. And it's relatively easy to find. You just go to ehospice.com to access it, and you can sign up to receive this is like a news service basically. Excuse me. Globally, it's a charity. It's a charitable entity in the UK, as we are, WHPCA, and our website is www.thewhpca.org, which is where you can find many resources on palliative care, particularly policy resources to help in developing palliative care. Also, our palliative care toolkit, which is a toolbox basically for how you develop palliative care in your own country, in countries with limited resources. So it's very practical, has a lot of step-by-step instructions on how to develop a service, what forms to use, etc. You can also find the atlas there, as well as other policy resources that, for instance, examples of national cancer control plans that include palliative care, or national standards for palliative care. We have about 30 countries now that have developed national standards for palliative care. And also, reports on progress in palliative care in some of the key countries around the world, and how to do needs assessments for palliative care, which is usually a very good first step to take if you're starting out. We have done quite a bit of research on the cost of palliative care and the effect that palliative care has on healthcare systems. Because the basic argument that we have found in research that's been done mainly in high-income countries, but now some research from low and middle-income countries, is that what palliative care does is, by investing in home care, we prevent unnecessary hospitalization. And that is the basic economic argument for palliative care, that the additional cost of delivering these home care services is actually more than offset by reductions in expensive use of the hospital, but also unnecessary diagnostic tests sometimes, and treatments that are futile and likely to bankrupt families. We know that, at least in high income in the US, half of all bankruptcies come from unpaid medical expenses. And this is, not something, in terms of universal health coverage, that we don't want to see healthcare systems that bankrupt people and that cause great, economic and financial hardships. So palliative care is a value add in the healthcare system because of what we're able to do to provide more appropriate care for people. It's not less care. In fact, it's more care, more targeted care to the needs of a person with a life-limiting illness, advanced chronic illness, and people, from the results of quality measures that we've taken pretty consistently, will rate palliative care or hospice services as a better quality than other sort of usual care, like if someone's going to an outpatient clinic, or if they're seeing, or if there is a home care service but they don't have palliative care skills, or if they're in the hospital or in a long-term care facility, nursing home. Those sort of side-by-side comparisons for people that have died, and their families afterwards, sort of ranking or describing their experience of care, they generally will definitely say that palliative care service is superior. It's better quality. It's it's something that they couldn't have gotten through without palliative care. So from both the quality and the cost side, I think we have a strong argument for why palliative care is necessary in a healthcare system and improves any healthcare system, provided that the care is done, provided it's a quality service. And the kind of difficult policy issues that we've been wrestling with have been in now at least 80% of countries in the world. There is such severe restriction on access to controlled substances that the essential medicines that palliative care uses to manage symptoms and to keep people comfortable and improve their quality of life are just not available, or extremely hard to get. So from a policy perspective, one of the major goals of the global palliative care community is to remove unnecessary restrictions on access to these medicines. While it's a balanced approach, while maintaining and ensuring that these powerful medicines are not misused. At the same time, they have to be available for medical and scientific use. We have to have these medicines to control pain and to control other symptoms that patients frequently have near the end of life. So that's a battle that has been waged. We've worked through the UN General Assembly and the Commission on Narcotic Drugs and International Narcotics Control Board, and they have all agreed that the single convention that was originally developed to control these substances and that most all nations signed, it's been out of balance. That we need to have more attention paid to medical and scientific use. So that is a continuing difficulty, because many countries are just afraid of using these medicines and allowing their use, and they've been. They don't those restrictions were put in place actually before modern palliative care became available, and now we know much more about their appropriate use in managing symptoms and pain. The other sort of big issue in palliative care is that really a lot of it is about educating the health workforce that already exists, so that they can integrate palliative care into their current practices. We like to suggest that a palliative care approach is really necessary for a large percentage of people who use the healthcare system, people with chronic and advanced illnesses that eventually may end up having their life shortened because of their condition. The palliative approach is the right approach for those patients, and there are millions, many millions of people who can benefit from this. And it's simply because the providers never received any training when they went through their professional training in palliative care. They don't know what they don't know. We train many people around the world, and they tell us that they're almost embarrassed because they realize that there's so much more they could do for their patients than they thought. They thought, well, there's really nothing I can do, so they didn't do anything. Now they know that there are things they can do, and so they have the power to do those things. From a policy perspective, we said needs assessment is kind of the first step. It's important to also develop standards for palliative care at the national level, so that within a given country that it's clear what palliative care is and what it isn't, and that can include both the generalist approach to palliative care and specialist palliative care services. Most patients actually, if the healthcare system and people are trained in basics of palliative care, the majority of patients don't necessarily need to see specialists that provide palliative care. But there are many patients, maybe a third at least in most countries, that will have complex comorbidities and symptom management problems, and will need someone with a higher level of training in palliative care services. It's also important that it be recognized as an area of specialization in a country, that it's defined in law in the healthcare system, that there's national strategy for palliative care, and that palliative care is included in some of the other major national strategies like cancer control and NCD management, HIV, and for drug-resistant tuberculosis, all appropriate populations for palliative care. And yeah, so those are just some of the things that need to get done when you're developing palliative care at a national level.